All right, everyone. Welcome to Journal Club number 4 with the American Society of Cannabis Pharmacists. We have cannabis in chronic pain, and I think this is any cannabis pharmacist will agree the number one reason patients come into the dispensaries. Excuse me. I wish the pharmacies, uh, but probably the pharmacies as well. Something I learned in my experience with cannabis in chronic pain is how dreadful it can be for people's quality of life, and it really affects the people around them as well. And as a pharmacist, you want to be able to provide that compassionate relief. So cannabis is really a no-brainer, but we are fortunate to have a little image there. I think we go by TJ, or do you prefer Terrence?
Terry's fun.
Terry is fine. Excellent. And we also got Jeffrey, and I think Jeffrey is now on mute, but whenever you want to hop in.
Hi, yeah, I'm here too.
Welcome. Doctors of Pharmacy, excellent, and the authors of the paper we are about to review. And I'd like to talk about a little bit about your background, if you don't mind giving us a little bit of background of what you did, what you're doing, and we'll take it from there.
Sure. Thank you so much, and thank everybody for basically signing on tonight. I'm Terry Bellner, and I'm an assistant professor at the University of Buffalo School of Pharmacy, and I'm also the chief executive officer of a humble not-for-profit we have here in New York called, GPI, which is the Geriatric Pharmacotherapy Institute. Kind of like my roots, kind of where we started, but we've evolved since then. I spent probably the past 30 years doing work for just about every pharma innovator in behavioral health, and over the years, you establish that skill set so that you can effectively and thoughtfully participate in phase 2, phase 3, phase 4 trials. Our focus has pretty much always been on phase 2 and phase 3 trials. And as the principal investigator, you look at things differently. So a few years ago, Josh, it's been a number of years now, but when New York finally approved medical cannabis as a viable treatment, basically what we did was we got immediately registered and started to treat our patients. And because of my background, I approached this from a protocol-driven process. We had a lot of experience. We were part of the duloxetine development and their whole series of studies about neuropathic pain. And what I did was I thought that, the best way we should approach this, since, cannabis doesn't have a package insert, and since I spent 30 years helping pharma develop their package inserts as it pertains to efficacy and tolerability, I figured I'd apply the same, knowledge to approaching this particular treatment modality. So, we prospectively set up what we wanted to do because, to be honest with you, when we started, we had no clue. We had no clue as to, here in New York, as I imagine in other states, the health department established, certain ratios of THC and CBD. But, what does that mean? And we didn't know. And there wasn't a whole lot of definitive information about that. So we kind of formulated a plan and immediately got it approved by our local institutional review board that as we go forward in treating our patients in this way, with these metrics, to help as objectively as possible assess efficacy and tolerability, that it would add to the discussion. And so that's what we did. And this first little blip here in mental health clinician was our seriously very preliminary look at this. Since then, our data set has grown to, well over 80 patients. We've made presentations to the other ASCP, the American Society of Consultant Pharmacists, because we had a subset of patients that were over 65. As a matter of fact, we had a lot of them. And and then we also took a stab at the dose response at the American Psychiatric Association. I believe it was last May. And we hope to present our current data set, which has grown to, like I say, over 80 patients. Basically, the idea that we can, I think, with a fair amount of confidence, speak to the durability of the treatment over at least a period of 2 years, which I think is really important. When you talk about, I come from a behavioral health kind of background, and neurology and pain is not what we really do. But
yeah, I was expecting more neuropathic pain patients in your studies, so I think that was a surprise to me. Also, just to compare the patients or the participants you have now, and in the study, you really had how many people?
Well, this is only 29. This is our
29.
first look at this. We took a look at our first,
preliminary
that met the inclusion criteria, and said, okay, well, this is good. Now, as we move forward in our ongoing treatment and assessment, we have a great many patients who basically suffer from neuropathic pain, and we hope to present that in September at Pain Week, if in fact the abstract is accepted. But going forward, we're in almost submission level for an article in the Journal of Palliative Care that Jeff's been working on, and we're hoping to basically make a stab at that, because I'm the consultant pharmacist for a local comfort care home here in Rochester, and we've treated the 30 plus patients or more, end stage pain management, pretty much all cancer sufferers, but this was more about, like I say, it's a very preliminary, stab at this.
Terry, thanks for the intro, guys. Thanks for allowing me to present our work. So yeah, just to kind of tag off of what Terry was saying there, he made a protocol that we got approved by an IRB. First you wanted a little bit about my background. That's right. I was a student and Terry was my mentor. And so I did this first preliminary study was my research project for my P4 year. And I graduated last May, and now I'll be starting with MedMen next week in Buffalo.
So proud of you. Good job, dude.
Thank you.
There's definitely a lot of things that I wanted to talk about in this article, in this study, excuse me. So first and foremost, let's talk about the dose. Was this discussed with the pharmacist? Because I know there's a lot of different dispensaries that the patients could go to. So I'm wondering, was there a standard protocol that you had sent over to ensure that doses were consistent?
So I think Terry can probably speak more to the dose than I don't think we looked at dose in this evaluation.
No, we didn't. Actually, that's what we presented at the American Psychiatric Association last May. And we made we had more data. See that's the enormous challenge. Okay, what we do is we're a clinic that basically treats patients and assesses patients for all the necessary parameters. But it's been an enormous challenge, and we're about ready to put this up on our website. That there's huge differences in the dose of THC and CBD per puff of a vapor pen, and of course none of our patients quite understand that, and we kind of looked at that as our responsibility to do that. So we help guide them down that path, giving them options. Basically, I mean, and I don't know, I'm new to this industry. I mean, I come from a pretty much a lifelong career in clinical research, and the idea that you can go and you can pretty much order a 20-to-1 ratio THC to CBD, but that's enormously different per dose from dispensary to dispensary. And here in New York, all the products have to be labeled and they actually have to validate this with an outside assay as to how much THC and how much CBD you get per dose or per application, or per tablet. Per tablet. Yeah, and per serving. I like that.
Yeah, something I really enjoyed about this study is that we have both, a long-acting formulation and an as-needed. And I think the as-needed definitely comes into play when you talk about, a complementary or alternative medicine. Reducing opiates is tough, and it's not a life-threatening withdrawal, but it's very uncomfortable. So, as compassionate pharmacists, I think it's important. I know it's a small study, but I do like seeing reports that trend towards that, opioid reduction and improved safety, reduced harm, all things that we absolutely need. One thing I really wanted to know as soon as I started reading the study, I was curious if you guys did a pre-study drug test or a UA, because if you do have patients that are more aware or comfortable, dare I say, with the effects of THC, you're going to see them tolerate higher doses. So
yeah, exactly. It's a great question, Melanie.
Yeah, that's something for future.
Yeah, well, no. What we did was, and it's something that we could certainly explore, but it was patient reports, and we asked them all those questions, and in fact, we had some people that were frequent cannabis users, but the vast majority of these patients were cannabis naive, and then I also kind of lumped in, and in some of our more recent abstracts that we've presented, they were basically patients who may have, most of these people are 40, 50 years old. And so all of them tried pot when they were younger. But it was for an entirely different reason. And they actually were out to seek the euphoric effects of cannabis because they weren't suffering from pain at that point. But now that they are, we use that as a really reasonable screener for whether they could tolerate it or not. And of course, the one question I always asked was, well, did you ever get paranoid or nervous or jittery? And all of them pretty much said no, which definitely tends to bias the sample. But
the THC
on the other hand,
dominant. Yeah.
Well, yeah, exactly. But then, we're talking 20 years ago, and the cannabis you used to buy 20, 30 years ago is not the cannabis you buy today.
Said.
So,
yeah.
Right. So,
especially in a lot of our medical states, we're going to have concentrates, whether it's tinctures or highly concentrated vaporizing oil. So it's really important to understand that, that concentration not only concentrates the potency, but it can also compromise or concentrate the pesticides and the other harmful solvents that might be in there. So,
well, sure, and
quality is so
I can't,
important to our patients.
Absolutely, and I can't speak to other states, but here in the great state of New York, they pretty much grow all this stuff indoors, and our Department of Environmental Control dictates what they can use in the growing of it. So, we're not
it's really
introducing
tightly
any
controlled.
potential. No, there's no question. Which, unfortunately, is why it costs so much. But on the other hand,
Well, speaking of cost, I think this study also talked a little bit about the money component.
well, yes, and we've actually reported on our growing data set that pretty much has been bore out in our initial evaluation, that when you actually look at what health payers pay for narcotics, as opposed to the slowly escalating copays that patients pay, this is a seriously viable cost-effective alternative. And absolutely. I mean, what does a fentanyl patch cost? And at the end of the day, almost all of our patients, some of them have done miraculously well. They're completely off their opiates, where others have it down to the point of an occasional dose or two per week, which to me, is what opiates were made for. I mean, they're a medication that's enormously efficacious, but over time, its effectiveness, dwindles. And in fact, what you really truly need to do is consider all that, and if you can actually use it very intermittently, it's very, very effective. So that's one of the things we struggle with the pain clinics here in town.
Safer alternatives.
Well, it's a safer alternative, but more importantly, it's like, you don't want to abandon or discontinue all these patients' meds only because they test positive to THC. And we've struggled with that, but for the most part, I think
you
we've
have
come
providers
to
that think that.
Oh God, yeah. Rochester is the most conservative medical community in the United States, and see the thing that one of the benefits I think that we've had with this real kind of hands-on management is that our attrition rate is non-existent. I mean, the only time we haven't had, we've only had one patient that didn't really experience the success that, and I think her expectations were too high. But and she didn't give us enough of a chance, and she certainly didn't want to spend any money. But when you consider the cost, the tolerability, and the efficacy, there isn't really much of a comparison. I can't make a decent comparison as to another treatment modality. And granted, it's based on our very small sample, but that sample is now up to about 80 some odd patients. So, as we slowly tick away with this, I see that, there's certainly some shortcomings in our study. I mean, I'd love to do a placebo-controlled trial, but the last thing we reported on, which of course isn't a part of this preliminary evaluation, was, the dose response was very, very comparable to what Sativex package insert basically reported.
Yeah, nabiximols.
Well, yeah. So we're talking about it's been very replicable as far as,
especially with your patient population. They were seeking that approval for the spasticity, actually specific to MS, which I don't think you had any patients, but also talking about the patients that you guys had. I found spinal cord injury. That's huge. And, that is something I think a balanced ratio would be more beneficial for. We don't really understand the elusive mechanism of CBD there, but, even THC has been associated with neurogenesis. I have one story. I don't like to share it because I don't like an N of one all the time, but, I have all these stories of patients that gain the feeling back in their fingers and toes. And is that because of the THC or the CBD, or neither? Is it all in their head? I guess we'll never
there's
about the studies.
the power of placebo.
Absolutely.
So, yeah, I mean, we struggled with all that, And the one story that I like to tell is, we had a couple naysayers, and these were frequent cannabis consumers, sophisticated cannabis consumers. Both of them were disabled, chronic pain, the whole mess. And they're the ones that objected the most to the price here in New York, and would try it, and then they were happy, and then the one patient's life was changed, but then he stopped doing, which speaks to the adjunctive nature of this. He had a whole ritual every night of mindfulness and stretching, and then he started to feel really, really good, and of course he stopped all the stretching and the mindfulness, and the pain came back, and he said it didn't work anymore. And then I just spoke to him a week ago, and basically, he was very interested in getting his certificate renewed, because he tried a whole bunch of different sources, whether it was from Colorado or California. He has friends, obviously.
Yep.
And
Patients need access to clean and
yeah.
consistent medicine. It's a medicine. Why are we discriminating
Right.
it? It's mind altering. Sugar is
Well,
mind altering. We need to focus our attention more locally. And I think as a pharmacist, I didn't really know what patients were really going through, when they would come in for their pain medicines or, any mood altering medicine. And I think having to do like consultations one-on-one, it really opens you up and it forces you to empathize with patients. And, for me, it's like I'm screaming for, a product that we could have across state lines that would be very easy to integrate into our pharmacies. And, I look at Canada, where they've legalized recreational cannabis, and now their pharmacists, they want to get involved. They have a medical program, but it's stuck behind specialty pharmacies, and we don't even have that.
No,
We have so much to do.
Yeah, absolutely.
And another thing about the conditions that we're approved for, it really makes me think about the comorbidities, because each state is so specific with their approved conditions and, what qualifies as a cannabis related condition. But, I think when I think of the patients I see in Minnesota, a lot of migraines, a lot of fibro, a lot of diseases I've never heard of, which are associated with a lot of chronic pain and spasms. So it's really exciting to see data coming out from states. If you're interested in Minnesota's data, it is available publicly. You just Google MN Cannabis Program. I even probably Google MN Cannabis Data, DATA, and it comes up. And it's just really cool to see what other states are doing. Let's talk a little bit more about, are you still working with cannabis? Do you have any future projects that you're planning that you're comfortable sharing with us?
I can talk about that if you want, Terry.
Oh, yes, please.
Yeah, go ahead. Yeah.
Let's hear from you.
Yes, so we're going to do like a sub-analysis of, well, we were originally going to do a sub-analysis of sort of the patients in this study that are palliative patients, but now we've added some. So we're going to submit an article to the Journal of Palliative Medicine pretty soon, and that one, it'll include some of the rating scales that were used in here, like the European Quality of Life scale. It'll probably include the PQAS again, but we're going to add this quick, very brief nausea and vomiting rating scale too for that evaluation. Yeah. And we're hoping to have that published by the end of this year.
Well, if you don't have it written yet, I'll say, anything on sleep. I think we truly underestimate, sleep medicines, and a lot of our HRMs, our high risk medicines, are for sleep. So I need alternatives.
Absolutely. I think that's a really good point. And I think a friend of mine that is a pharmacist at another clinic in Buffalo, she focuses a lot on PTSD. And I think that sort of finding a good measure for sleep and then doing a study with her patients would be really cool too.
Absolutely.
Yeah,
cool.
Plus, this September we're gonna, like I said, if the folks at Pain Week basically accept the abstract, we'll be presenting the entire data set, which is I think it's about 87 or 88 patients. I mean, there's no question that a randomized controlled trial would have been, much more credible. On the other hand, a large simple trial makes a world of sense. And as we slowly, tick away at getting to that much larger database, we're going to continue to report on our experience, because here in New York, there are countless prescribers that are certified to prescribe cannabis. And the problem is, and it was a very disturbing statistic to me, a couple of years ago, the health department here in New York basically reported that out of the 50,000 people that were registered, only 20,000 of them ever returned for a second visit to a dispensary. And a lot of our colleagues here in New York pretty much make the recommendation that, they kind of leave it up to the dispensary as to what to use. And that's fine and it's wonderful, but as time goes on, it's almost like, because these dispensaries get very busy, and it's almost like going to Walgreens and saying, gee, I'm depressed, and my doctor says give me an antidepressant, and basically having the pharmacist basically have the time to basically determine which one might be best for them.
But that really brings us back to the purpose of cannabis. It's a quality of life-saving drug, and that's what we do in pharmacies. Patients have a quick 1-2 heartburn, fever, whatever.
Right.
We ask the right questions and we counsel appropriately. And I think, if we had better provider status, if we could bill for our services, anything, it does make an impact, and it helps us get away from the purely dispensing model. We have such a vast clinical knowledge. You need to know how the body works in order to manipulate it with drugs. This isn't novel. So, if we could get ourselves out there, and man, I'd love to see cannabis behind the counter available by talking to your pharmacist.
Absolutely.
But, do a lot of these patients need to have, every 3-month checkups with their doctors, depending on their condition, and especially if they're able to reduce or discontinue their opiates, that's powerful, and it's empowering for other patients. And I think slowly but surely, its effectiveness, its safety, it is truly being shared across the country, across the world.
Basically what he realized is that the dispensaries had really poor retention, and part of that was because the pharmacist at the dispensary doesn't necessarily have the time or the incentive to really individualize treatment for these patients. Like the dispensary business model is based on volume, right?
Yeah. Well, I don't know. It's a little bit different in Minnesota, where the pharmacists are required to provide that recommendation, where in New York, they have the option where the doctor can provide it, or the certifying physician, or the pharmacist, if there is no order. And that's how Pennsylvania is as well. And, I think we should be encouraging pharmacist autonomy, where, we can make these clinical decisions. I'd like to see more and more research come out from states where pharmacists are involved in the dispensing. And if we can make those comparisons, I mean, some people truly need to see it written in a paper to believe it. And for those people, I think we need to go the extra yard or the extra mile.
That's a real good point you make, Melanie. I mean, there's nothing like the power of making a recommendation, i.e. a prescription or whatever you want to call it. What it does is, see, the industry, my take on the industry, because, we did some field work in Colorado when we were at a CPNP meeting a number of years ago, and went to a recreational dispensary, and the person at that dispensary was an enthusiastic consumer who basically had incredible tales of success. And in fact, if we had translated that to our practice here in New York, I don't think any of our patients would have come back. But the I think the point is that we need to treat this like a medicine. And if it's a medicine, you've got to know exactly what the dose is. And you know, as we move forward with our ongoing expansion of the knowledge base, you know, we need to be able to show, and some of my colleagues at UB actually have the assays, and now we're talking about the infrastructure necessary to get some, you know, really decent, you know, PK correlates and PD correlates to serum levels, and then, you know, from that point on, you know, we can basically make a reasonable stab at a dose response, and I think that's essential. That's essential to our ongoing success, because as Jeff pointed out, you know, the attrition rate is enormous with this product, and that's not been our experience. Our experience is I can't get rid of these people because you know, they experience a real positive effect, and it's a durable effect and an extremely tolerable effect. And the goal here is not, you know, intoxication. The goal is relief and an improvement in their quality of life. And you know, you've got to be able to do that with a well-defined dose. And unfortunately, that hasn't been fully established. But we're working on that, and we're going to get closer and closer.
Yeah,
So
I think we need more pharmacogenomic studies as well. I think,
well, there's that.
Metabolite is probably kicking ourselves.
Well, there's you know, we just don't know a lot about this, and when you let it be a consumer-driven decision, and think about the outcome. Think about somebody who's depressed, and we would say, oh, well, you need an antidepressant. Go figure it out yourself. I mean, we would never do that. I mean, that's just not good medicine. But that's kind of like what we do with cannabis, and it needs to be, because the patients really appreciate it. I mean, you know, as far as seeing them every 3 months, that's you know, after a year or so, I mean, you gotta look at, you know, I've been doing this for a real long time, not the cannabis stuff, but pharmacy, medicine,
Patient
research
care
stuff.
yeah.
Yeah, patient care stuff, yeah. And you know, when you back away from this, it's like, you know, you have to really look at it like nothing works better than something that's directed by a health professional. And
Yeah, placebo,
you know,
needs that person to be there to tell you it's going to work.
well, exactly. And it's like, well, wow, you know, it's like I said, you know, that one little story I was saying, you know, my two naysayers are back again, and they can't compare it to anything else. And like, oh, Terry, you know, this has helped more than anything. And, you know, I really like this product from this dispensary, and I like this product from that dispensary. And just to reverse the choices here in the great state of New York, and we only have 5, 6, maybe soon to be 7 different dispensaries. All the products are different, and to help them navigate that, so that, you know, we're focused on a dose and a response.
I do agree that, you know, I think the biggest difference between New York and Minnesota is we just have 2 manufacturers that make cannabis products. So it's very easy for me to look up those products. But, you know, in states where you have so many, I think, you know, more than 10, it's very difficult to control, let alone, you know, you don't know what's coming through. So it makes it more difficult.
Well, that and the recommendations as far as the dosing recommendations, you have to make them dispensary neutral. So it's
Well,
like,
yeah,
you know,
that's how most people learn about cannabis. You know, they don't learn about the bubblegum kush or, you know, the play, whatever they're calling it these days. You know, they look at the ratios, they look at dosages. You know, we use our knowledge as pharmacists, we use our knowledge and apply that to formulations, and we can, you know, easily interpret, you know, what an inhaled medicine will do versus sublingual versus swallowed. So, you know, we we're not new to this. And I think, even though we don't have very strict guidelines or algorithms that follow our dosing, it's that compassionate care that you're talking about, that, talking to patients, understanding what they're going through, actually identifying their goals of therapy. All of this is so important to, helping our patients find relief, and, just being encouraging as a career. I think a big problem with retail, that's where I don't want dispensaries going to. I don't want it to feel like that. We shouldn't have drive-through, let alone in dispensaries. So,
well, no, I can't agree more. And
yeah.
the only thing I would add to that is that the European Pain Council or something just published a paper. I haven't had a chance to read it except for the abstract, but I plan to read it, as to their recommendations and how they pretty much are really supportive of the notion that only trained and skilled clinicians should be prescribing this, because that's what maximizes outcome. And the idea is that as we move forward, I would think that the American Society of Cannabis Pharmacists should get a panel of experts together to basically come out with some dosing recommendations, because whether the prescribers here in New York or any other state want to follow that or leave it up to the pharmacists at the dispensaries, that would be a real strong place to start. And
Absolutely. Yeah, we have committees meeting, and not just talking about dosing, but the terminology we use. I think your experience in labeling and the package inserts, that's so important. That's how we are able to quickly and effectively look up information about the drug in question. So having a standardized nomenclature first and foremost. So it's kind of alarming. Just, it's not taught in pharmacy or medical schools. All the information available is part of it's misinformation, and it's very difficult to weed through it, if you get the pun. But any final thoughts before we sign off here? Oh, actually, I had a thought real quick. So sorry. So you were talking about that article from Europe. If you wanted to, if anybody wanted to, continue the discussion, if you wanted to go to our website under resources, you can hit Journal Club, or you can just find this Journal Club number 4. There's also a search bar, but feel free to add a comment. We'll be able to, keep the discussion going, and, let it ride. So any final thoughts from our esteemed attendees?
Well, my only final thought is, thank you for basically starting this. I think it's a great idea. It is a unique practice setting. Jeff came in second in Farm Tank at APHA, presenting our treatment model just this past month, and it's definitely a very viable career path for pharmacists and pharmacy students that is in its infancy. And I mean, we can't even get an approved P4 rotation at a dispensary.
Oh, wow. Well, that's not true. That's not true. I have colleagues.
No, in New York. SUNY wouldn't allow it. So, and I'm
okay. Well, that's certain places, and I think
yeah,
everyone's so afraid of losing funding, but I really don't see anybody going through such lengths to interrupt that care. And nursing homes, schools,
but
waste of time.
I mean, I've had a rotation here, and my students were instrumental in developing our website, in some of our definitely patient education materials, and they all loved it. So I'm about ready to retire from UB, but the point is that we need to get more established I give you a lot of credit for getting this started. You know, and if there's anything I can do to help in the future, I'm in 120%.
Oh, thank you. I like hearing that. Yeah, we definitely, want to encourage participation, and feel free to reach out. Feel free to share with any other organizations you think would be interested in collaboration. Oh, and then there's a little chat here. Thank you, everyone. I will get this recording squared away, and then I will share it once it's available. Make sure you're signed up for our newsletter, and I will find the link.
Thanks, everyone.
Thank you. Yeah, thanks, everyone, and I'm looking forward to it.
Excellent.